All right, everyone, welcome. Let's jump right into today's topic, which is amyloidosis. Now, I know this one can seem a little intimidating, but I promise, by the end of this explainer, you're going to have a really solid grasp on the core pathology, how we diagnose it, and what it actually does to the body. So, let's get started.
So what on earth is amyloidosis? At its heart, it's a disease of misfolded proteins. Normally, our proteins fold up into these beautiful, functional 3D shapes. Think of a perfectly folded key that fits a lock. But in amyloidosis, for whatever reason, these proteins misfold into something called a beta-pleated sheet. Now, this new shape is super stable, but it's also totally useless and insoluble. It's like that key got melted down into a solid, useless block of metal. And these blocks start piling up outside the cells, that's the extracellular part, just gumming up the works, putting pressure on everything, and eventually causing cells to give up and die.
Okay, so this raises a pretty big question, right? We've got this microscopic junk building up in the tissues, but you can't see it with the naked eye. So how in the world do we actually find it and prove that it's there? This is where the magic of pathology comes in.
To see these invisible deposits, we use special stains that are designed to stick specifically to these amyloid fibrils. They're kind of like a highlighter for pathologists, letting us zero in on exactly where this harmful protein is accumulating when we look at a tissue sample under the microscope. And there are two main stains that you absolutely have to know.
So let's look at how we visualize this stuff. On a standard H&E stain, which is our basic everyday stain in pathology, amyloid just looks like this smudgy, amorphous pink material. It's a hint, a clue, but it's not definitive. The real money, the gold standard for diagnosis, is the Congo red stain. Under normal light, it makes the amyloid deposits look red or orange, but, and this is the part you need to burn into your memory for exams, when you flip on a polarizing filter, that same Congo red-stained amyloid glues with this incredible apple-green birefringence. That unique optical property is pathognomonic. It's the smoking gun for amyloidosis.
All right, so we've seen it under the microscope. Now, what do these tiny deposits actually do to the patient? Well, the clinical picture of amyloidosis can be all over the map because the symptoms depend entirely on which organ is getting clogged up with this protein gunk.
Let's talk about the big three targets. First, the kidneys. They get hit really often. When amyloid deposits in the glomeruli, the kidneys filters, it messes them up, causing them to leak massive amounts of protein into the urine. And what do we call that? Nephrotic syndrome. In the heart, the amyloid fibrils get in between the muscle cells, making the heart walls really stiff and rigid. This means the heart can't relax and fill with blood properly, which leads to a condition called restrictive cardiomyopathy. And in the GI system, deposits in the liver and spleen can cause them to get really big, which we call hepatosplenomegaly. That's your classic triad of organ damage.
But it doesn't stop there. Amyloid can mess with a lot of other systems too. It can infiltrate nerves, leading to peripheral neuropathy. It can deposit in the tongue, making it unusually large. That's a classic physical finding called macroglossia. It's also a big cause of carpal tunnel syndrome. And in the skin, it can give it a waxy texture and make the tiny blood vessels super fragile, so patients bruise really easily, especially around the eye.
Okay, so we get the general idea now. Protein misfolds, deposits, and causes problems. But now we have to get more specific, because amyloidosis isn't just one disease, it's a whole group of them. And the way we classify them is based entirely on which protein is the one that's misfolding. Here's a little tip. The name of the amyloid protein usually gives you a clue about where it came from. This table breaks down the major systemic types. Let's walk through it. First up is primary amyloidosis. We call this AL type. The A is for amyloid, and the L is your big clue. It stands for light chain. These are fragments of antibodies made by rogue plasma cells. So you see AL amyloidosis associated with plasma cell diseases, most famously multiple myeloma. Next is secondary amyloidosis, or AA type. The precursor here is serum amyloid A, a protein your liver pumps out during inflammation. So it makes sense that you see this type in patients with chronic inflammatory diseases like rheumatoid arthritis or Crohn's disease. Then there's transferrin amyloidosis, or ATTR. This can be hereditary or it can be just a consequence of aging. And finally, dialysis-related amyloidosis. This is caused by a protein called beta-2 microglobulin that doesn't get filtered out well by dialysis, so it builds up over years and years.
Now, not all amyloidosis goes systemic. Sometimes the protein deposition is stuck in just one single organ or tissue. We call this localized amyloidosis, and it's actually behind some diseases you're probably very familiar with.
Let's look at some high-yield examples here. Alzheimer's disease, those classic senile plaques in the brain, are made of A-beta amyloid. Type 2 diabetes? Yep, a protein called amylin can form amyloid deposits right in the pancreas, which can hurt the insulin-producing cells. Medullary thyroid cancer is another one. The cancer cells themselves crank out so much calcitonin that it deposits as amyloid within the tumor. And in many older individuals, you can find isolated amyloid in the atria of the heart, which is linked to atrial fibrillation.
Whew! We have covered a ton of ground. So let's take a moment and just boil it all down. Let's focus on the absolute highest yield points that you've got to have locked and loaded for your exams. This is your crash course summary.
Here it is, all in one place. If you remember nothing else, remember this: the core pathology, extracellular beta-pleated sheet deposits. The pathognomonic finding, apple green birefringence with Congo red stain. You gotta know that one. The key associations, AL amyloid goes with multiple myeloma, and AA amyloid goes with chronic inflammation. And for the clinical picture, think of the two big ones: restrictive cardiomyopathy in the heart and nephrotic syndrome in the kidneys. If you know this table, you are in fantastic shape.
And that brings us to the end. I'll just leave you with this final thought to chew on. Since we now know that all these different types of amyloidosis are caused by different specific proteins, what does that mean for treatment? Well, it means the future is all about targeting that one specific problem protein. The real challenge now is to develop drugs that can stop the misfolding or maybe even clear out the deposits for each specific type of amyloid. And that's really the essence of personalized medicine in action for these diseases. Thanks for your attention, everyone.